Good evening, everyone. For those of you who are living in Pennsylvania or some of the other states that are voting today, happy primary election day. My name's John Dahl, and I am your moderator tonight for our weekly COVID-19 town hall with Dr. Sanjay Udoshi. This will be, I want to be careful that we don't read too much into this word. This will be our last meeting town hall. Next week, we hope to be starting a webinar series town hall. We have a lot of people that are participating now, and we've kind of outgrown this platform. So this will be our final platform. The webinar in the coming weeks will still be streamed on Facebook and YouTube and all those sites. So excited about that. For those of you who have joined us, you know the drill. For those of you who are new to us in this format, you have a chat window here in your Zoom window, or if you're watching on Facebook Live, you have the chat stream. The chat stream that we pay attention to, or I watch very closely, is the one on Sanjay Udoshi MD's page. If someone's shared this or is doing another meeting, you may not see your message, but you're always welcome to join the Zoom as we go. And with that, I'm happy to turn it over to Dr. Udoshi.
Thanks, John. So hello, everyone. This is our 11th town hall, and I'm extremely proud and happy to have with us a special guest who will be talking about the psychosocial impact of COVID. And I'll be doing a more formal introduction to Dr. J.J. Rasimas, but he is a friend of mine from childhood, basically, and it's just an honor to have him with us. So one other thing I will mention, that he is in the city of Minneapolis right now, and that's where he lives. And we thank him again for making himself available. I know that it has been an extremely stressful time for all of the residents of Minneapolis and St. Paul. And you know, we extend our love and support to him, his healthcare community, his friends, and even those who surround him in his neighborhood. So that being said, I'm going to cover a few topics very quickly because the remainder of the town hall will be entirely devoted to allowing everyone to interact with Dr. Rasimas and also ask questions. We want this to be an open discussion. We found that all of the town halls that we've conducted that were conversational rather than driven by some PowerPoint or something else have been the best ones. And we feel that opening up as soon as possible for those conversations results in a very productive town hall. So that being said, I will cover a few topics very quickly. The first one is that as an observer and somewhat assisting in the process of addressing COVID throughout the country and more locally here in Pennsylvania, I've been observing the briefings of the secretaries of health throughout the country. Some of them are extraordinary. Some of them are really, really models that should be held up. There's a gentleman in Lincoln, Nebraska that I've been posting to the resource page who does a 10 to 12 minute summary every day. And it's an extraordinary expression of information about his community, but also about the national trend. Here in Pennsylvania, I follow Dr. Rachel Levine, who is our Secretary of Health. And I want to mention something very important about some of the observations that I've had in being part of the briefings and watching the interaction between the press and her, as well as the questions that come live off of the web. Nearly 80% of the comments from the public have been extremely hurtful and derogatory. Dr. Levine is transgendered, and the transphobia, the hatred, and the bigotry that she has to work in that environment and see those live messages stream by has got to be, you know, horrifying. And I would like all of us here in this town hall to understand how demeaning that is and how detrimental it is to the entire process of information sharing. One, if you are, sharing derogatory comments during her a live stream, you're distracting yourself and you're distracting others who are missing the message that she's trying to share. And sometimes that message is extremely important to your safety. Okay, so if you know anyone that's doing it, tell them to stop. It's unacceptable. Okay, she is highly qualified. She's highly intelligent. She is in service to the public, and she deserves our attention and our respect. And I, for one, won't tolerate it. And if I see others doing it, I will call them out. Why is this even a healthcare issue? Why am I bringing it up in town hall? Well, today we're talking about psychosocial health. We're talking about mental health, and we have one of the country's premier experts. I can't put it any other way. So open your minds and hearts, let go of prejudices, and ask him questions. These are healthcare issues to me when I hear that an EMT committed suicide in New York after weeks of suffering the horrors of bringing patients to the hospital, gasping for breath. 23 years old. It becomes a healthcare issue to me that a woman, Black woman who had struggled through poverty to become an EMT is shot and killed in Louisville. And the community is shocked by that. There is a psychological effect that we must examine, and we must bring forward as healthcare professionals. She's part of our family, and we take care of our own. And so I will bring that up as well. There is harm being done to healthcare workers. It is in words, and it is in the form of self-harm. We've seen a physician take her own life in New York, and it is the trauma is real, and then we're here to examine that. Okay, on a lighter note, I think I saw Larry the Cable Guy's Pennsylvania cousin. So I went down to the convenience store not far from my house, and in front of me stood a 6'4", 240-pound man with a flannel cutoff shirt, okay, huge work boots. The guy was just a mountain, and in his big left fist is a bunch of Slim Jims and hard packed pretzels, and he's got a real tree hat on backwards, camo, right? Okay, camo hat, real tree. And he was still trying to, make his selections when he noticed me behind him. And he turned, and I could see a very neatly placed surgical mask, a very kind, courteous man doing his part. So we throw out all of these stereotypes, okay? We embrace those who are doing their part. And it's just that simple. He's not screaming, "This is tyranny." He's not, he's an example. And the more examples like that we see, the more we should embrace them. We should thank them. It's called positive deviance, because if we show them our thanks, they pay it forward. Okay. So it's not just, what are we called? The lockdown fanatics that are, paying attention and doing the right thing. It's everyone that has to go out and work every day, and they're paying attention, and I'm proud of that. I've said this town hall after town hall. My locals here in Northeastern Pennsylvania have been amazing, and 80-90% usage and whenever I've gone out, masking and distancing and being kind and courteous towards each other. Okay. So I'm going to introduce JJ now, but I have two more points. The battle is lost in the United States against COVID. We have to come to grips with that. We have blown through any attempt at containment. Our mitigation strategy has failed. We have lost over 100,000 Americans to this disease. And we have the highest number of deaths and the highest number of cases in the world. So we need to face it now. And in contrast, and as evidence that we have failed, we have other, developed nations, the OECD nations, as we call them, like Taiwan, New Zealand, and South Korea, that have done an outstanding job of containing the disease and protecting their populations. We have failed. So now we have to deal with the consequences of that failure. And one of those consequences is the sequelae. The sequelae in the psychosocial and in the actual physical morbidity that comes with thousands of patients struggling, hundreds of thousands of patients recovering, struggling to recover, and carrying the disease burden with them, not just after they felt better and the fever has come down, but now for months and maybe even years. So that's why the New Zealand model is the victor and the Sweden model is the failure. And you will begin to see the Sweden model change, and it will start to selectively lock down populations and selectively go forward with a more serious strategy on how to lessen the impact. Okay, on that, protests here in the United States. I was very harsh on my personal page towards the protesters that were, anti-lockdown and urging us to get back to work and all of that as fast as possible. Very harsh with them, with the fact that they showed up without masks and they were, in the thousands. And here in Pennsylvania, at least it was small, it was in the hundreds, but in other states, thousands. Now there are protesters in the tens of thousands in our city centers, variable mask usage, extremely angry, screaming, chanting, and I have to say that this is they're putting themselves and others in extreme danger. It's not just the protesters. Protesters are coming into these city centers from a radius of 100 miles or more, and then they're going back home and taking potentially that exposure with them to their communities. So I'm protesting from right here, okay? If you've seen my page, you'll know I'm livid. But I'm protesting from right here, and I urge all of you to do the same, all right? Protest with sensibility and safety, make your voice heard, but getting out there with thousands of other people is absurdly dangerous. You're putting yourself and your communities at risk. I have to say that. All right, the rest of it is not very important. I'll cover it. I'm excited to get JJ. So I'm going to introduce JJ. So Dr. Rasimas has a Jesuit university background. He studied biochemistry, mathematics, and philosophy. He completed medical science training at Penn State University, earning his Ph.D. in chemical biology in 2002 and his M.D. in 2003. After his psychiatry residency and training at the Mayo Clinic in Rochester, Minnesota, he became a clinical fellow at the National Institute of Mental Health, training in consultation-liaison psychiatry, bioethics, and clinical research. He received the Institute's highest honor for clinical care, the Hannah Cashman Memorial Award. Dr. Rasimas has studied psychoanalytic psychotherapy at Minnesota Psychoanalytic Society and Institute and the Washington School of Psychiatry. So he has also completed critical care medicine toxicology. He's the only physician in the country that is dual boarded. So he completed his critical care medical toxicology fellowship at Penn State, obtained his board certification in addiction medicine, and then returned to Bethesda to the National Institute of Health. And you will see pictures of us on my page from when I went and visited him a few years ago, and he was still at the NIH. And that was a wonderful dinner, JJ. Sorry. After returning to Bethesda and the National Institute of Health, he joined the Undiagnosed Disease Program, an Intramural Research Program to oversee clinical trials in mood and anxiety disorder. So as a fellow of the as a fellow of the Academy of Psychosomatic Medicine, as well as the American College of Medical Toxicology and the American College of Psychiatry, Dr. Rasimas has a background also in emergency psychiatry. And he'll talk a little bit about what he does on a daily basis now. He's currently the director of consultant liaison psychiatry at Hennepin County Medical Center. You will know that name, Hennepin County, because it is the one in the news for the last 4 days straight. He teaches medical students, residents, fellows, and candidates in psychoanalysis across the Twin City region. And JJ is a full professor at the University of Minnesota. So he's pursuing academic medical career at the interface of psychosomatic medicine, medical toxicology, bioethics, and psychoanalysis. His primary clinical interest is in the phenomenology of suicide. And that's one of the reasons I'm really happy to have him here tonight, because we are as a society in a very, very difficult place. So with that introduction, I'll hand it over to JJ to describe a little bit more about himself and what he's doing, and then we'll open it up for questions.
Thank you, Sanjay. It's true that I work in the hospital that was part of George Floyd's extended family. And so although we are here to talk about the coronavirus pandemic and the old entrenched pandemic we have in the United States that took George's life is now intertwined with the new one. That is the starting point for my current experience this week, and so I apologize for the rather subdued presence that I feel like I already am just by joining. This is a somber time, and boy, the interface of the two problems together is really, really weighing on us a great deal in our hospital. But I'm still very grateful that I'm able to be back home in northeastern Pennsylvania remotely this way during this time to talk with the community of people who are still close in my heart, even though the pandemic has made it so I haven't been able to be home in quite some time. And I do wish that I could be, for sure. So thanks for having me. That hospital that I work in is a level 1 trauma center in the heart of downtown Minneapolis that takes care of some of the most disadvantaged people in our country, really. We are an urban center like many others, and there are areas of our cities where people have very little in the way of resources, and there are hospitals that have always been dedicated to taking care of them. And so although our hospital doesn't have a big flashy academic name attached to it, I'm really proud to be part of the operation there because of who we see. And so that relates to why we have to take both of our pandemics that have now converged on us this week so seriously. I am deeply troubled by the fact that the protests conducted the way that they have been, and the breaking of our physical distancing that many people have embraced to try to stem the tide of the pandemic is now going to make things even more difficult. Not to say things weren't already difficult, but you see, just like a lot of folks on the news are talking about how the protests are harming the very community of the people who have been harmed by Floyd's murder, that terrible irony, that irony is going to boomerang back as well, because those who have underlying health conditions who have not received good health care along the way before they are exposed, as you know from previous iterations of this activity, are those at higher risk of suffering a greater burden of COVID disease and more likely to really end up in a terrible way by contracting the infection. Well, who are those people? They are the friends and close contacts of many of the people who are on those streets. And so we're very frightened about what's going to be facing our hospital soon. We have done a very good job comparatively in Minnesota to flatten our curve, and it's a marathon, but our populace up to this point recently had embraced it. And so although our numbers of cases had been growing, and you'll see on those maps on CNN that Minnesota is always red, meaning our cases are increasing, but they're increasing tiny bits each day because we're in the middle of the country and we were exposed later.
Yeah.
What that meant is if we took it seriously early, we were able to make a major difference in how things were going. But now, of course, we're not so sure that all of those early efforts are going to hold. And in fact, we're really more sure that we're going to be facing some trouble.
Yeah.
So that hospital, that level 1 trauma center, is almost like a mini city in itself. It doesn't have that many beds compared to a lot of medical centers you've heard about. It only has 440 total spots for patients to be in. But it has all of the bells and whistles of everything available to try to take care of the sickest patients, from burn specialists to the highest technology for cardiac and pulmonary support. And so that kind of a hospital has to have psychiatric consultants who are available to help with the mental health needs of people who come to the hospital for other reasons. And that's what I do. So consultation-liaison psychiatry is the subspecialty of psychiatry dedicated to assisting patients whose primary problem at the moment is not necessarily a psychiatric one, and also assisting the doctors, the medical teams, and the nurses, and the other folks around those patients who are in that moment having a really terrible medical or surgical problem and need psychological support, need expertise in the biology of the mental experience of being sick, and assistance for how really even care teams get along. You know, the more complicated a patient gets, the more conflicts there are about what the right thing is to do, and the stress is hard on doctors and nurses, and they don't always treat each other well around patients, and everybody can feel the tension. And so that's what our job is to be not only experts on the ground, but also be a kind of container for some of the difficulty that hits the hospital. And I have to tell you, despite all of what I'm rambling about the hospital experience, the thing that troubles me the most is, by the numbers, our service has been a little less busy over recent months, not more. You might think it would be more total numbers of patients, but it's actually less. So why is that? Yeah. Well, the flattening of the curve and the real push to try to keep patients away from hospitals unless they absolutely need to be there. That's a message that our folks have gotten in our community. And in some ways, that's a very good thing, to try to preserve the hospital space, to not infect anybody else who needs to be, who doesn't need to be exposed already, right? So we have had fewer total patients in the hospital recently. We've done that intentionally. And then, because of who those patients have been, they haven't come with their standard difficulties that we see regularly on our consultation service. What do I mean by that? I mean lots of drug overdoses, purposeful ones with the intent of ending one's life, accidental ones because of addiction, lots and lots of psychosocial problems that are part of our day-to-day life. For many reasons, those patients are not coming to our doors. But many of those people are homeless. They have very few resources. I worry about them a great deal at a distance, but they're just out of my reach. I don't get to be with them the way that I used to be. Now I have a different cohort of patients, and we'll talk about what the COVID experience of being in the hospital from a psychological standpoint is. But I just want to acknowledge that because the whole landscape of public health and approach to this situation has changed things, there are communities that used to benefit from having the hospital almost like a second home, a safety net for them when they needed a place to be, when they needed shelter, when they needed to escape domestic abuse at home, when they needed to address hunger, when those basic needs. The hospital is one of those sanctuaries, but they're not permitted in now the way that they were. Our doors are more tightly shut to those kinds of problems in the interest of doing better by the pandemic management, which is not a bad thing intrinsically, but there are consequences. Yeah. So the work in the hospital has changed. Also, the experience outside the hospital has changed. The other thing that's changed is, I've changed. Like, this is the way that psychiatrists dress now when they work in hospitals. Yeah. I'm wearing a strange scrub outfit, which I'm sure those of you who saw the advertisement were expecting somebody in a bow tie and some patched jacket or some weird thing like that. Maybe I should have a cigar at least while I'm sitting. But this is the outfit, right? Because we're trying to stay clean, even though we have to be right up in the spot. And the last thing that I would say about being right up in the midst of this in the hospital is we're sensitive to the reality of limited resources. It is difficult to be close to people the way that we used to be. Some of our cases where we assist, we pause for a moment and wonder, should we as psychiatrists, who aren't technically essential to save the physical life of the individual in question, should we be burning personal protective equipment when there's a shortage of it, because our standard routine of going into the room, sitting down and being present and being close to other people's bodies is no longer allowable in the same way. And so since it isn't, then we wonder about the best way to go about it. People don't see my reactions to their reactions the same way anymore because I'm covered. I was tempted to actually show up and have my first appearance here on the webinar be covered the way that I'm covered in work, and use that as a sort of strike way to talk about how this doesn't feel like psychiatry, and probably what you wouldn't expect from your therapist or someone who is really supposed to be attuned to your human experience. And that is really, that's troubling to me. I do not like operating this way when I depend on so many other ways of communicating other than just words that are shared through a mask like this in a way that you can't really hear, let alone all the other things that are supposed to be shared. And so there are technological interfaces where some consult psychiatrists like me work through an iPad, or will talk to their patients on the phone and look at them through a glass window. I've done some of that work sometimes too, until we got our PPE scaled up enough where I could be deemed an essential person to wear it. I did consultations like that, and that is painful for me as I watch the pain of being alone in the hospital. Not to mention the aloneness that comes from separation from family, which of course you've seen in stories all over the news. The missing family at the bedside is something that really weighs on all of us, because we learn as psychiatrists to treat people as part of a family system, as part of a social network of relationships. We don't just take care of individuals if we're doing it right. We're thinking about how they're seated in their world, but now they've been extracted from their world and dropped into an ICU, and they're having a terrible time, just as their families remotely are having a terrible time.
I want to pause here because I want to synthesize a few things, and then we had a long conversation the weekend before last in an open office hour. It was the first of the kind, where I'm inviting just professionals, and we don't have an audience. As you know, you and I spoke for almost 2.5 hours, and you related to me, as a professional and as a colleague, your experience over the last 4 to 6 weeks, including losing a patient to a suicide, while the patient was under your care in the hospital setting. I don't know if the patient was necessarily under your care specifically, but I'm saying in your hospital. And you just talked about how a lot of the surrounding society or community that would normally come to you for other care needs has not had access to that opportunity because of the circumstances. And one of the things that John and I do is try to provide reasons for people who have a lot of questions about things that they hear in the news. And one of the things that people have been hearing in the news is that hospitals are mostly empty, and 70% of ventilators are, we're using only 30% of ventilator capacity. And so all of the fear mongering that was early on about how this would overwhelm our healthcare system, was really unfounded. We'll get to another question later on about whether we overreacted, but in your estimation, and I'll allow Karen to ask a kind of a synthesis question that she and I put together before the show, that really melded together 37 different questions that came from people who wanted to speak to you, but definitely wanted to hear your answer, even if they couldn't make it tonight. So Karen will ask that. But is there now are we now creating a backlog of care needs unaddressed, that that you're going to have to, and specifically your community in psychiatry is going to have to deal with? Is there a surge behind the surge when it comes to what people will require of you and before you answer that, the second part of my observation here is you talked about how these patients, many of them may have to spend time on a ventilator. They can't even communicate their fears or their, their emotional state. And that has presented a new challenge. A lot of these patients have heard that this is a killer, and that if they end up in the ICU, there's an 80% chance they won't leave alive. Or even if they are coming in with a mild or moderate course of disease, fever and flu-like symptoms, they're coming in with a great deal of fear about the outcomes, and their families have a great deal of fear. So I guess just to hit pause and give you some framework to talk about what it's like dealing with these patients to start with, and then obviously the outpatient scenario that you see as an impending need once things, well, I don't know when, but once things start to change when it comes to the response to this disease.
I think that the way that you've asked the question really does highlight the key pieces of it. And so I'll really just kind of pick those up again and sort of relook at them in an answer and try to be fairly succinct. Different levels of experience really are vastly different when it comes to trying to figure out how to be most helpful. Sometimes it can feel almost dismissive to some patients to be struggling with symptoms, present for a test, have it return positive, and get the news from their treating physician, whoever interfaces with them, that they do indeed have an exposure, and what they are feeling physically is due to being infected. But because they don't have a need to have oxygen in order to sustain well, because they are stable enough to be able to eat and drink and basically care for their own bodies, they're dismissed in the acute hospital setting to go back home and begged to expose as few other people as possible in quarantine during that time, during recovery. And even that experience, although that's actually the good outcome in terms of the physical experience and the threat to life, that is different from much of people's medical experiences up to this point, right? You get this very threatening and anxiety-provoking news, knowing that it's possible that you could progress to serious disease. But in that moment, you're told, we're not going to have you come into the hospital because there's potential that you could progress to that disease. We are intentionally going to turn you back to go home and have you decide whether or not you want to pick up the phone again or call back or come back or let us know what's going on. And most importantly, go home and endure it alone. This is new in the experience of medical care for most people who have been patients before. And if they haven't been patients before, forget new, this is disheartening. This seems like it's not care. Like, wait a minute, so this is what it's like to be a patient with this? I know that that's strange to say that, but I'm trying to speak to more of the human psychological reality of the experience rather than clinicalizing it and saying, well, I can tell you all the reasons why these patients come in the hospital, these patients are on observation status, these people go here. We can talk about the medicine, but how about the human experience of having all that worry and getting that really horrible news of, yes, this is positive. Now go and contain the entire experience yourself.
At home,
for the sake of society and for the sake of all of the rest of us and the beds in the hospital and this and that. Even though that is the least critical version of COVID disease, right?
Yeah.
That there's asymptomatic, right? People carrying it around. But
yeah.
If you have any manifestations of disease, in that case, you go home and you endure it alone. And that's, of course, we've been told that is the largest percentage of people who do become symptomatic. So what does that mean for our mental well-being? We are being told intentionally to go be alone, not just be alone in the service of us protecting each other, but now you've got the disease, but go be alone. Go suffer alone. Go nurse yourself. Don't be with somebody else to have support. Think about the human animal in our societies. For so long, we've gotten used to sickness behavior and like, oh, don't we love it when our wife makes us chicken soup? Don't kids love it when they get tucked in by loving parents when they're having a terrible stomachache? None of that anymore.
Yeah, the care experience is broken down.
Not one, but very little of that. So even though we can talk about the higher levels of sickness, and we can chat about the ICU experience and the hospital experience itself, I just wanted to highlight the fact that the majority of people who suffer with COVID and the psychological effects don't come to see me in the setting where I work.
Right.
They go back home and they have to endure it alone, and their contacts with the world are just like the ones that we're having here at best.
Yeah. So one other point that I want to add to that observation is that when you send them home, I think this is the wrong strategy. This is, my background is in decision support. It's in population health and data. So I look for patterns and I look for reasons for good outcomes and reasons for bad outcomes. To simplify it. So I think that this is a really bad strategy. Not just from your perspective of the psychological need for care in a care setting, because that's what we do in a hospital. That's a care setting. And an ideal care setting involves the care team showing compassion, empathy, and involvement in the process of healing. That's absent. Okay, that's absent in this disease right now because of the, keep them out of the hospital thing. All right. And then they're going, I don't trust these people. I'm sorry. I don't trust that they are not going to go and try to get what they need, or they have in the past 4 to 6 weeks left their home to go get what they need because they don't have a care team around them. Okay? They don't have the resources to have someone look after them through the worst of this disease. And I don't doubt that is not an insignificant, how we use the word, not an insignificant mode of transmission in the community. They're not in the hospital being isolated from the community and being taken care of. They're not having their care, their psychological and physical care needs met. And doing it by themselves is putting themselves and others at risk for poor outcome.
Because they don't have options, right?
Yeah.
Because they have to choose between going without food and basic necessities or finding those on their own because no one else can do it for them. That is one of the key reasons why this illness differentially afflicts our disadvantaged people from the beginning, because we can give good, sound general advice for all of us, right? Because we're all potential walking petri dishes equivalent to the virus. The virus doesn't care. It's thrilled that everyone is out protesting. Right? But those different folks, then when you think about how their lives are set up and what their options are, vastly different in how capable they are to actually listen to the guidance. And it isn't largely through their fault. There are plenty of people to fault. And you and I, as you've talked about your social media presence, you're angry with folks who break the recommendation strategy when they don't have to.
Yeah.
See the other side of the coin with so many people who truly do not have another choice.
Right.
And cannot follow the guidelines.
Yeah.
Because we do not have a public health response that is set up to make this better. And so when we talk about these layers of difficulty, the thing that troubles me the most when you started our discussion this evening by highlighting that by many measures, we actually have failed in the United States to do this as well as we really needed to save lives.
Yeah. Now, one of the things that we had a couple of weeks ago, we were hoping, and it's going to be this Sunday, and JJ, you're welcome to join. Dr. Daniela Marasco from Italy has been sharing her experience as a treating physician in a hospital setting in Italy. And they took the opposite approach. The hospital became their piazza. They invited everyone to it. Get out of the community, come here. And that's why you saw their system overwhelmed very quickly, right? You saw that in Foggia and in other regions, Lombardy. So I wish I could pronounce those Italian names correctly. But anyway, so let's take a step away from hospital medicine and into the community for a moment, and then we'll come back to this. Karen, do you want to ask JJ that question that we synthesized?
Sure. Hello, doctor. I'm right next door to you in Milwaukee, Wisconsin. So when we had the pandemic come to our shores, we had to make a decision on how to manage it. And obviously, there was the opinion that this could easily swamp our healthcare system. So of course, we instituted a lockdown of sorts where people were non-essential people were asked to stay home. And it's been 2 to 3 months, and obviously we saw the bending of the curve and it's working. But there is a counter conversation going on about the diseases of despair that are happening. People have lost income for 2 to 3 months. They're isolated. You talked about the isolation as well. It's all a very nuanced balancing act that we're doing, right? We have these lives that are being lost if we don't manage the curve correctly. But then on the other side of the coin, the diseases of despair that might be impacting people, from the loss of, like I said, the loss of financial support, the loss of interactions with people. So we have suicides, possible drug addiction problems. Is there a quantifiable way to, is there any quantifiable way to measure and basically figure out where a balancing point is? Do you have any data, any statistics around that? One thing that we did find is that of 40 million people laid off, that 30% of those people are below the poverty line. And you talked about when they're below the poverty line, they have less options to help solve some of their problems. So can you talk about that a little bit, that balancing act?
Yes, that really is an outstanding analysis and fusion of sets of concerns in a way that is extremely difficult to pick apart in a way that we would have agreement across all of our leaders, our decision makers, and our society who would be asked to trust the analysis. It's very, very difficult to do it. Sanjay mentioned that we lost a patient recently in our hospital who was not infected with the disease, but was extremely frightened that he would in fact contract it, was sure that he would die from COVID during this terrible time, and became so overwhelmed while being treated for another problem in the hospital. By the way, what was that problem? He had been assaulted on the street by someone who decided that the resources he was carrying around with him were precious to the other person to the degree that they would hurt him to do it. So he was recovering from traumatic injuries and then took his own life. And so when you think about the person who assaulted him and the pressures on that individual to commit a crime that may or may not have occurred before the crisis that we were in, and then the experience of that individual having that taken from him, suffering physically, and then being sure that COVID was going to take his life, and then he literally acts to do it, it's very easy to put together an algorithm that would say, yes, that man goes in the column of horrible but clear collateral damage of COVID, who didn't die from infection, but absolutely died because of COVID. So that's clear. So if we were to try to put together a model, that kind of case would go in that equation that we would like to put together. The problem is the more and more variables that come together in a way where they contribute a little percentage here, like 5% extra stress because of finances, 10% extra stress because of hunger, 7% more because the only thing that I can do to keep myself from feeling hungry is to use a stimulant that'll calm my belly, but then I get more edgy, I get more reactive and irritable, and then I get in a fight with somebody. You see how it's extremely difficult to make a really good claim that there's a cut point, right? There's a line where you say, these deaths are from the disease, these deaths are secondary to the disease directly, and then these other deaths, quote, would have happened anyway. And the would have happened anyway thing is really part of what's weighing on all of us as we have this debate, right? So we absolutely don't want to lose more total lives by the policies that we implement. But it's extremely difficult to figure out even how to put those numbers together when we also have an opioid epidemic that has been taking people's lives along the way. We simultaneously take people off the roads, and we have fewer traffic deaths than we have had in years and years and years. We decrease pollution rates. We almost certainly lose fewer people to asthma flares during the time of not putting more pollutants in the air because we're home and not driving. All at the same time that, as you say, individuals are suffering mightily at home. They are despairing, their health suffers, and let's add another layer of complexity. Even if they don't kill themselves or drive an addictive disorder forward past the point of no return, even if it's not obvious what happens, what if the mere being at home and putting off the management of chronic conditions means they die sooner because their high blood pressure isn't managed and they have the stroke that they never would have had because they can't get to their primary care doctor? So all I'm really doing is adding extra layers of despair to your asking me, so fix this. And what I'm telling you is that I really do feel the pressure to come up with a better answer. And I have to tell you, I do think that the answer exists. But it relates to what I was mentioning before when I alluded to Sanjay's intro. When Sanjay introed and said that we have really failed in many ways, if we had a much more robust response from the top down about the most critical areas of response, meaning the need to control the virus spread so it didn't kill people, there would have actually been space to add on the extra layers at the same time. And so what do I mean by that? Well, let's think about the metaphor that a lot of people like to traffic in for reasons of either convenience or to communicate the emotional problem of this. They liken our dealing with this pandemic to a war, right? I want to talk about it like it's a war against the virus. Okay, so let's harken back to a war that we really did actually do a pretty darn good job with when the world's integrity was threatened. In World War II, not only did this country step up with tons and tons of manpower and resources and got behind the right stance when it came to defending the very humanity of vulnerable people, a continent and an ocean away. In order to make sure that we all got through that time, remember what else we had to do? We mobilized all these essential able-bodied folks to go and pick up a gun and defend. But who backed them up? Tons and tons of otherwise homebound people who used to have different jobs, teaching, taking care of households. And what did we do? We asked many, many, many women to pick up a riveter, right? To show up in other places they had never worked before. There's an analogy in that to this situation. We do have to have frontline people. We called certain folks essential and then labeled other people non-essential. And that distinction was awful when we failed to fill the void and lift everybody else up at the same time in the response, right? So we divided people. And in some ways, my life was easy. How was my life easy? My life didn't change. All I do is go back and forth between my house and the hospital. And the difference is I have to have this extra burden of calculating what I do with PPE. But I still have a job. I've lost very, very little in terms of my resources. So yeah, I'm a healthcare provider on the front lines and people calling me a hero. I hate that because it's easy for me. The people for whom it's hard are the people who are told, you are not essential. Stay home, have no salary,
and do nothing,
face starvation, do nothing, and do nothing for everybody without a vision, right? And so if we had had a better response for the first layer of everything that we needed, masks, ventilators, and done that really, really right from the top down, the next layer that really would have followed logically would have been what FDR did during the war and beyond. He said, we need, and before, right? Works Progress Association, all of those jobs, all those people in that era of our America who needed something to do that would feed them, that would keep their bodies moving, that would keep them engaged, and let them all know that they were part of the overall fight. So there was a way to do that here too. We could all be exhorted to be connecting with each other, to not leave people who are suffering at home alone, but we should all be reaching out. There should be a network of electronic ways of contacting, maintaining social distance, having at least some physical closeness to each other so that we can support each other emotionally, but still maintain enough distance that we don't pass the virus. There are ways to do this that we could all be doing for each other. And it's great that we're all getting together because we're doing it for each other by emoting and sharing information and seeing each other's faces. But we need to scale up these kinds of activities in a way that we do this for everyone. That's what is missing in the response to the pandemic, is the extra layer of forgetting that these are human beings. These aren't just petri dishes. They're human beings. They're not just numbers. And so the right response has to involve giving people jobs. So you can no longer be on your assembly line. Now you become a contact tracer.
Yeah.
You can no longer do your job in retail because we can't do retail the way that we used to. Now you are going to be a support buddy to someone who is sick. You're going to do shopping for people and drop off groceries so people who are really infected don't have to come out. And then we're going to pay you to drop off the groceries, right? New jobs in a new time for a new problem at all levels, not just essential healthcare people and everybody else. But there are tons of jobs that could be done now, but we have no leadership saying, let's reorganize society and the economy around them. And so people are just losing jobs without getting a new one, even though, hey, I got hundreds of jobs I could give people to take care of the folks who I see or I hear in my psychiatry practice who I can't go to anymore. We've got jobs, but we didn't retool the economy. So instead of saying it's an automatic compromise between money and the economy and COVID deaths, what we really need to do is retool the economy itself around the reality of COVID and then lean in and pay through it rather than saying it's one or the other. There were options available to us, but we're just playing catch up.
Now, before we do any solution engineering or, discuss, the next 8 weeks or the next 10 weeks, I do want to take a pause. There is a gentleman that I invited to share an experience with you. I hope he's still with us because it has to do with what you just discussed. Can a community be involved in preventing, or can a community be involved in assisting us in suicide prevention, in detecting when a person is heading towards a problem with drugs and addiction and all this other stuff? So is John Davies with us? Giselle, can you guys hear me?
Yes, we can hear you. John,
Hi.
Hi.
Hey, John, I'm so glad you could join us. I'm not sure if you were able to pick up on the conversation so far, but at this point, I would like you to kind of provide any context you wish at whatever level of detail, obviously protecting privacy and other concerns. Questions and concerns regarding the effect on communities and whether communities can be, what questions would you have for Dr. Rasimas about impact, reaction, community, suicide, and all of these diseases of despair that we're trying to figure out whether we're doing the right thing?
Well, I'm not sure I can frame it as a question, but
Then, yeah, an experience.
I'm a lawyer in a small community for about 30 years, and as such, outside of my actual formal clients, I have many people who come to me for as a listening ear, and maybe a few words of wisdom to help them track what's going on in their lives. So I'm in a period of reflection now because one of those people just took his own life and his wife's life last night in this community. And this is a salt of the earth person who works very hard, was under tremendous pressure politically through zoning issues and so on in the community for years. And I just have to speak from my thoughts and process at this point. This is the last person you would want to put in isolation outside of his normal support networks. He's an energetic person. He's full on. He's a bull, basically. He's strong, energetic. He was a metal recycler.
Okay.
So he's out there every day interacting with the public, and his web of support would be in the neighborhood of hundreds of people, of which I'm one. I haven't seen him since February, March. Normally, I would run into him through the normal community interactions, and we might have a conversation. And that kind of conversation wouldn't be like this, and it wouldn't be 6 feet apart shouting at each other. It would be him talking quietly and into my ear because he doesn't really want to publicize his business. So we have our styles of communication that are intimate, and there's warmth, and there's connection, and there's support. And my reflections now are really, and this reflects on me personally too, because my entire life vanished. I was proactive in what I call health and wellness, being retrained and re-educated. I'm 72 and I was getting younger by the day. So I just sent Sanjay my risk assessment, basically, of my chances of getting COVID are so fractional that I stopped being worried about it a long time ago. I'm in the best health I can be, and I maintain my health. And despite the fact public health gives me no advice on immunity, I know how to take care of myself. So I may get it, I may not, but I think the chances are low. On the other hand, I just assessed myself
Sure.
as suffering from probably likely 50% less life expectancy, because I expected to live to 100 and be in vital health. Percentage loss of vitality, increase in anxiety and depression, and all these things that I've been coping with. I live with other people, so I'm not isolated and alone, but I'm cut off from my normal support network.
Yeah.
And I see it in the eyes and the faces of the people that I see. And we're now over the fear part where we actually aren't afraid to talk to each other in the parking lot outside the grocery store.
Sure.
Thinking that we're going to be reported to public health. Somebody's taking pictures and sending us in. So that's kind of gone. And we can even have a hug and not be afraid the police are going to come. So, but I look at this whole thing as the most traumatic experience of my life. And what I read tells me that other people observing, I'm not sure whether our doctor guest today is of this mind, but we're going to be dealing with this for probably 10 years. In terms of untreated health conditions, people that have not had their diagnosis, not had their biopsies, not had their whatevers, in terms of increased stress and trauma and the sequelae of that, that I don't know where this is going. I don't know if the activities that I've lost, they're not regainable under the social distancing rules. They were dance, yoga, theater, things that require people to be in close contact, and that I was thriving on it. And the other people I was with thrive on it. It's gone.
Yeah.
And that's not a trivial thing. And neither is the usual small town interactions where we listen to each other, we share our problems and our issues with each other. And we don't go to professionals because we have support systems.
Yeah.
But that man who took his life, you don't isolate him for 8 weeks. And as soon as this started, we knew in the news there was a rise in domestic violence. You know, this is not a surprise, and I've been putting it out there And I've actually blocked a couple of people who just don't get it.
Yeah.
They're very unempathetic to this issue. And to me, I see what I call lockdown privilege, people that maybe actually had no social life before this, and now they can get together with other people and do lockdown support activities. So they're having a great time. Or other people who are now getting $2,000 a month in Canada, which is more than they were making, and they're having a party.
Yeah.
So there's that side too, but there's also this huge downside, which we're now dealing with in our community, and it's very tragic. So thanks for giving me some airtime here, Sanjay.
Oh my God, John, thank you so much for joining us. Really, I could sense that your perspective was important for us to hear, very important, because I've been pressing science for the last 8 weeks, and the importance of understanding, all these nuances of molecular biology and all this other stuff. But the reason I'm so proud and happy that we have JJ, and I'm also extremely honored that you were able to join it and share with us, is there is such a human cost. There is such a human cost that is not being assessed. There is such a need for us to discuss how to do this properly and correctly for each other's psychological health, which has been, as you said, and I think also JJ would agree, largely ignored through this whole thing and unassessed. So what is the real cost of what we're doing? And I'm not talking about financial costs. What is the real cost to humanity, our humanity individually and collectively, to what we are doing? And whether, not whether, how far along are we on the wrong path, and how to turn around and get on a different one that is more effective. I'm still a hard science guy. I'm still going to ask for, the things that are going to create effectiveness, and for, happiness needs to be part of that equation, right? I have largely ignored people's happiness through this, and I have, I'll admit it. I've been very harsh. Or you don't like wearing a mask, you think it's tyranny, too bad. But there's real stress that's associated with some people having to wear a mask for as short a duration as half an hour to go in and out of a store, having anxiety disorder or other disorders, and then as long as 10 to 12 to 14 hours in a work environment. So I'm getting off course here. What I'm saying is I really would like us to take the time to examine what you just described. And I'm going to hand it over to JJ for his thoughts.
JJ's just taking a brief break.
Okay.
He'll be back.
If I may respond to your mask comment.
Yes.
In the context of what I said, when I go out in the community, I'm reading people. I'm not just saying how are you in a routine way. I'm actually reading people, and I'm meeting what I see their needs might be. Mm-hmm. Masks remove that ability to connect as well, even with social distancing.
Yes.
I can't see how people are doing.
Yes.
Right. And that's very important to my style. Right. It's also, I think, important to other people, but it also affects me not to be able to do that.
Correct. That's beautifully said. Yeah, it's beautifully said. Yeah, I mean, I think JJ mentioned that in our conversation last week. He said, well, I mentioned to him it was week 2 of what was happening throughout the world, and I'm making observations from my colleagues all over. And the first time I had seen a medical team in Israel, fully in protective equipment, they had realized early on they had lost the patient connection, the human connection. So they had printed their faces on paper and taped it to this is who I am. This is the smiling face of their, who they are, who's coming to their bedside, because they had lost that, right? And that was in the healthcare environment, but now you're talking about in the community. You're all walking around without being able to read each other, to actually see what someone is feeling. And in a very, very close-knit community like you've experienced yours is, that's extremely, it's a huge loss. Sorry,
I think Mr. Rogers,
go ahead, John.
I think Mr. Rogers should be an advisor.
Yeah, yes, absolutely. JJ, were you able to capture or follow some of our conversation so far?
Oh, yes, I was. And,
Okay.
I really like it that John's commentary came on the heels of Karen's question for me, which, I must confess, I sort of reflected back in more complexity because I don't have an answer. But as I hear what John said, and I think about the themes that are embedded in Karen's question, the thing that comes to my mind is that we as human beings have always simultaneously put great value in what makes us similar to each other and the same and brings us together. And at the very same time, we very much do value our own differences and our individuality. And thinking about those two concurrent themes of what it means to be a human being in parallel and doing our best to try to integrate them, hold them in tension, balance, and really recognize them, truly recognize them, is I think where the right pathway through comes out. What do I mean? So there's a sameness to the reality, as I sort of flippantly said, we're all petri dishes before. We are all the same in that way in terms of what we as bodies add to the risk pool for all of us as a community. So that's a biological, that's a physical, related to the pandemic similarity. We also have some similarities in that regardless of our differences in terms of who we like to hang out with or how we do it or how we associate, Aristotle said we are political animals, and he used that term with a small p, meaning the way that we organize, the way that we think of ourselves in relation to others, and the way that we go through as part of a species, collectively, but as individuals, it defines who we are. So that's a sameness. But there are vast differences. Some of us have a really strong risk toward having an addictive problem, and that's dangerous in a time where we might now be indulging alone and not have the balance of people to keep an eye on us or support us in our sobriety-based communities where we need that togetherness. I think of Alcoholics Anonymous trying to find ways to meet at a distance now when they have depended for decades on sharing horrible coffee, having a cigarette outside, and meeting together with hugs and closeness of sharing of testimonials. And now they can't do it the same way that they did anymore, right? And so there's difference there in that group's risk, where now other folks say, well, I don't really care whether the liquor store is an essential business. That doesn't mean a damn thing to me because I like iced tea, So look at that difference. And so how the person who drinks iced tea could very easily then say what? Close the damn liquor stores.
Right.
This is simple, this is easy. And the folks who have a very different relationship with alcohol say, how could you possibly dismiss me along with you're throwing me out with your policy that you say is mathematically based and the right thing to do. And so I really love it that Karen asked her question, wondering about the possibility of some sort of mathematical equation. But I want us to be anti-mathematical and cut through it with something that is more nuanced and honest about humanity. And what would that mean? Practically, that would mean recognizing that there are some people we need to find very creative ways to be closer to, even if the risk is a little bit higher.
Yes, okay.
But they will die if we don't do it that way. So we've got to find, and that would mean, making sure that we can keep chemical dependency treatment programs open, keep social programs open, think seriously about what it means to have a church community function, but also balance the reality that mega church behavior in its traditional way is absolutely not acceptable because we're going to kill people, right? Yeah. But there's got to be a way that flexes, that recognizes difference.
Yes, I love that you brought that up because, yes, absolutely, the differences it's so crucial to embrace the differences. So one of the things that came up earlier, I think it was 5-6 weeks ago, why are they keeping the liquor stores open? And a bunch of doctors said, do you know how many people would show up at the ER with DTs? That's what we call the delirium tremens, the
horrible alcohol withdrawal.
Yeah, horrible withdrawal. Because we don't want them, we don't need them near our hospital right now. Keep the liquor stores open. And it wouldn't be a few, right? It would be hundreds, perhaps thousands, that are daily drinkers and heavy drinkers. And we don't have the bandwidth to deal with them right now, but we let them, it's not ideal, okay? There are certain things that are not ideal. That's one category. But I think that one thing that John brought up which is another positive deviance, and that's negative. That's how we deal with a negative problem. With a positive deviance is you've got a community. Should we have, and should we still allow people to feel different levels of risk? Okay, so for example, we said all across Pennsylvania, whether you live in the middle of the state with 1,200 other people, or whether you live in a suburb of Philadelphia, y'all are going to have the exact same requirements, okay, of how to deal with this.
Right.
And so when you blanket requirements, you're taking people's autonomy to make the risk assessment themselves, right? So I know that even the difference between me and the way I behave in the back mountain of Wilkes-Barre versus the way I behaved when I went to see John today, okay, in Wilkes-Barre, is different. I knew I live in a lower risk environment 4 miles away from him.
Yes.
Okay. And so what John was mentioning about, his routine of assessing his community members individually being lost just by the fact that they're wearing masks. Were they all necessary? Was there even a COVID risk for some? And that's another failure of data, right? On my end of the spectrum of healthcare is evidence-based action, right? So was there data enough to say John's community has to behave the same way as another community, right? So anyway, so go ahead. I'm going to leave that open to you to talk about.
Oh, it's great. I don't have too much to add, except it has me associating to something which, is a little dicey because it's not the forum here. But think about one of our major political problems we have in the United States. We have an urban-rural divide. And one of the things, although certainly it does not define every individual's life living in every city versus every Holt and Heath and farm community, it doesn't define each individual's experience. But in general, we might have done a better job of meeting the needs of most urban dwellers and most rural dwellers had we been honest about a differential risk right from the beginning and said, those of you who live in cities, guess what? You already know that your lives depend on an intrinsic level of trust of many, many more humans on a day-to-day basis than people who live in the hinterlands in lower population density. You've already embraced this, right? You walk out into an intersection based on the color of the traffic light, and you trust all those cabs to not plow through and take you out. Those rules are set up for the cabs to behave and you behave. And there are countless ways in which when we have higher population density and people coming together, people who thrive on those kinds of environments and choose to live in them also have already acknowledged that there are more ways in which their own behavior and the behavior of others are defined by some guidelines. And so if you ask that population to please, pretty please, with sugar on top, wear the mask.
Yeah.
Say, well, sure. Relatively speaking, they are more likely to embrace it quickly and say, yeah, I get it. I'm constantly within 2 feet of spitting distance of so many people every day. I totally get the idea. But why in the name of God, as you said, ask somebody in the middle of a wheat field in North Dakota to do exactly the same thing when they have up to this point lived a life that has not been defined by tons of rules to govern safe interactions with tons and tons of other humans, because that's not how their lives have been. Do they need to be now to the same degree? And that's really disheartening that we didn't recognize that aspect of difference.
Yeah.
And the reason why I pointed to politics gently earlier on was think about the redness and blueness of those places, and think about the kinds of leadership problems that we've got, and think about the areas of resistance to science and guidelines. We didn't actually have to get heavy-handed with folks in those redder areas in general and say, you must, you must, you must.
Mm-hmm.
We could have said, just think about this. It could be coming to your area. Please be thoughtful.
Yeah.
And would be some good things to do. And that level of intervention would have been, in terms of the need, equivalent to really telling people in cities,
yeah,
stay in, stay in, stay in. And those, bluer folks who tend not to automatically resist those kinds of edicts would generally not have been dissatisfied either. We right? So we could still do that. I'm not saying, I wish we had done it. The opportunity's lost. The opportunity is not completely lost to actually relook at that.
Yeah.
But we have a leadership void. We've got some great ideas that we share here in this webinar, but we have a difficult time taking what these neat things that pop out of our chat and putting them on the desk of somebody with a big signature, to
well,
make.
I'm happy to say that I've been in communication with Dr. Levine. I have email. I've emailed her a paper that was talking about instead of R naught, there's a P naught, which is progression to zero. Okay, and progression to zero is a very hopeful metric. It's not daily. This is how many people died, and this is how many new cases there are. It's I suggested that they transition to a progression to zero, where every county has a 7-day moving average of how close they are to zero new cases and zero new deaths. And so, yes, they're there. They're willing to listen, and especially the ones that are not seriously overburdened right now. I mean, there's the doctor in Lincoln, Nebraska. There's others that I'm communicating with and saying, there's a Dr. Lisa Sanchez that is trying to get a grip on her metrics out in Arizona. And so she's saying, patients are coming in from this zip code, they're getting admitted in this zip code, and where they tested positive and the case counts are all a mess because the data is not appropriately reported and appropriately curated and all this other stuff. So, but back to the point that you were making is, can we now re-engineer our approach to this on a community to community basis, and will that have benefits? Because clearly it will. I mean, just clearly, what I was talking about a couple of weeks ago here was green, red, yellow. Okay, if your community's been green in terms of its population density and transmission, then you should be able to live differently than a community that is under a great deal of risk. But the only way to assess that is with testing. Okay, it's not guesswork, it's testing. And then we had a lot of questions a few weeks ago. Wow, you can't test everybody every day. Yes, you're right, you can't. So you do it by their exposure to risk. If you're Dr. JJ Rasimas and you're going to the hospital every day, you should have the opportunity, if you're definitely going to be, in exposure, getting tested twice a week. If you're living on 144 acres and your entire social bubble is 7 people and a horse, you can get tested a month from now and then 3 months later. But at least put yourself in the data pool, please. You know what I mean? Like your negative result is as important in nowhere, Nebraska as it is in Wilkes-Barre, Pennsylvania. I want to know you're negative in Wilkes-Barre, Pennsylvania, and I eventually want to know that you're negative in Nebraska too. But where the risk is highest, you know, we're not telling people that.
But the important question we have to ask is, how often does the horse have to get tested? And with that, we need to take a quick break. We've mentioned Dr. Rachel Levine a couple times. Every week I play this clip, so I'm going to do it again now. This is Dr. Rachel Levine, our good friend, the Pennsylvania Physician General and Secretary of Health.
Thank you.
Now here are my daily reminders. Please wash your hands with soap and water for at least 20 seconds, or the time it takes to sing happy birthday twice. Use hand sanitizer if soap and water are not available. Cover any coughs or sneezes with your elbow, not with your hands, and try not to touch your face, especially at touching surfaces. Clean surfaces frequently. And if you are going out for life-sustaining activities, please wear a mask if you're going to come in contact with others. Practicing these everyday prevention measures can help slow the spread of the dangerous virus, COVID-19.
I want to thank Sanjay. Just a side note, you had mentioned some of the folks who were saying some not so nice things about our friend Dr. Levine, and so thank you for bringing that up. And hopefully you're in a good conversation with Rachel and Sarah over at the Department of Health. I've worked with them for many years, and happy to have been able to help you connect with them. So hopefully they listen.
Yes, yeah. I'll keep checking with them. You know, there's our resource page, and I hope for them to take some time once in a while to follow. Like I said, we've now segmented our resource page into the page, which is really directed towards people not in the healthcare community directly. And then we have the resource group, which is people who are really interested in observing what's going on in the scientific and biomedical community. So that's where I'm posting the papers and things like that. And that's where I will continue to send her team and let, you know, it's curated by me and others with commentary from, as you know, doctors across the world. So we'll get into that later. But let's get back to the conversation, if we could. Let's catch up on questions or comments if we can. Karen, do you have a summary, or should we just kind of read off the group chat? I'll let you do it, Karen.
I don't have any specific questions for the doctor in the chat, but do people have any right now that they might want to unmic and ask?
Yes, great idea. Let's do that.
Yeah, I'd love to be able to take the balance of our time to have direct dialogue about really some specific questions if they're really more pointy. Because we've been talking in broad strokes and these themes have been really great. But if folks have specific things they want to comment on and ask about, that would be really great.
And if people are watching through the Facebook Live, feel free to post your questions there. I've also included a link on the Facebook Live if you'd like to join the conversation through the Zoom interface and join us with a webcam or a phone live. You certainly can do that. I have a quick question. I have a question that to get us started, and that is, let me find it here. So looking on the brighter side of things, maybe, obviously mental health, healthcare has had to really reinvent how we do things during this. You had mentioned people talking, JJ, you had mentioned people talking on an iPad or whatever. Do you think, if we think longer term, that some of these accelerated technology solutions will help over the overall mental health of the world?
I do think so, John. I am optimistic that way. And I have to confess that psychiatry as a discipline has been reluctant to be customer service focused, when in reality, large portions of our society have been begging those of us in mental health to become more flexible in the way that we deliver ourselves to be helpful to the society that we serve. And now, frankly, the pandemic has forced us to embrace things that folks have been begging for us to think about for a long time. Now, I talk to my psychiatry colleagues and therapy colleagues regularly, and they say, no, whether we really get a handle on the coronavirus and can go back to something completely normal, I can bunny ear the heck out of this all day long. But the idea is we're never going to go completely back to the way that we delivered our care in our specialty of medicine and really in any other. There are always going to be folks now who say, I got my therapy during COVID via telemedicine, and I really found that convenience was much better because, frankly, going across town when I've got kids to take care of and 15 balls to juggle in my life, it serves me better to be able to meet with my therapist for 1 hour without that having to take me 3 hours total in order to engage with the treatment, because I can do it where I am, and I want my therapist to meet me where I am. And so meeting people where they are in their struggles during this time actually should generalize in a way that we're going to deliver treatments better. So, there had already been designs on mental health apps to be able to not only support people, but also gather data that then doctors could use to assess symptoms over time and provide care and respond more quickly without having people have to come into the office or wait for the next available appointment, which those of you who either have mental health conditions or know someone who's got one, it takes months just to be able to get in the door with a psychiatrist in a clinic.
Yeah.
Well, that actually is not the way that it is now. Access, although it's not the same kind of access, in some ways has actually increased. It's become better. And we have psychiatrists saying, this is a crisis. I owe it to my patients to reach out to them. Now they're making more phone calls. They're checking in. And they're actually having more encounters with their patients than they did before. Paradoxically, some things have actually improved. We just need to be flexible to realize that we could do that at many levels. We could do it at the psychiatrist level, the therapist level, but also the social worker level, the case manager level, the community organizer level, the psychosocial treatments that are group-based rather than individual. We all could be working at that different level to be able to have more contacts rather than sitting around saying, I don't like the no-show rate in my clinic. How am I going to fix this? Well, you can fix it by picking up the phone.
Yeah.
Really. So there are absolutely opportunities baked into this crisis. There really are.
So John and JJ, I am pleased to see, and this is a lack of proper coordination on my part, Dr. Anna Perez is a PhD social work, and she has joined the conversation at exactly the right time I'm seeing her. So Anna, if you don't mind, just do a brief introduction, and if you've got any thoughts so far on the conversation. Sorry to put you on the spot, but this is a very informal town hall. So love to hear your background and your thoughts on what you've heard so far and your perspective on how social work is going for you and how things are in this era.
Thank you. So quick background, I currently work at two hospitals right now. I work both in acute care and the emergency room. I got my doctor of social work from University of Southern California. Right on. So I'm a licensed clinical social worker, and I am also a licensed chemical dependency counselor. So my focus, you mentioned about the opioid epidemic, that was actually my focus when I was doing my dissertation.
Yes.
Just my thoughts on everything. I think by nature, it's been kind of hard. I have experienced where, the hospitals for a while were, it was the dip, or we did have a census dip. What I have seen, the two hospitals that I work at serve in my city. I live in San Antonio, Texas. We're about 2 hours close to the border or whatever. We serve the lowest socioeconomic demographic. So many of the people we see are unfunded or they're underinsured. And I tell people you can have insurance, but you can also be underinsured. And we serve a lot of the homeless, and we serve a lot of immigration.
Yeah.
So I see this. My focus specifically is on addiction and trauma. And what I am seeing, and everything you guys were saying, I was listening and I was like, yeah, yes, yes, yes. Like enthusiastically, I was fangirling all of you. Was that we have seen this. I do go to some of these Zoom AA meetings and NA meetings, and I'm seeing a lot of people. We're talking about 10 plus years in recovery without having that social connection. We are seeing relapse. Yeah. I've been seeing it. It's very difficult. I've had these conversations with these people in the ER who are saying, you know, doctor, I don't understand. I don't get it. I thought I was strong. And I'm like, well, it's not every day that you go through a global pandemic. It's not, you know. Right. I don't think, I don't know if people didn't take this serious enough. I don't know, or we just didn't know, or people just didn't educate themselves, or the powers that be, like certain administrations, didn't put the information out there. I'm not trying to put my political bias in there, but anyway, but it's true. But it's true, right? But it's true. And I'm seeing a lot of relapsing. From what I have seen, at least, you know, at least for my geographical location, I'm seeing a lot of relapse with the methamphetamine use. A lot of people that have not been able to get that in-person connection in regards to mental health, because not everybody's gone telehealth. I think telehealth might be the way of the future, but not everybody's done it. So for a lot of these people to go and start that, you know, to have that interruption services, I'm seeing it. It's caused a lot of family disruption, because for a lot of these people, when they relapse, there's other biopsychosocial factors that will play into that. Now you get involvement with law enforcement. Now you get involvement with child protective services, things of that nature. And therefore it's causing family separation. A lot of people are not considering that. Of course, then you had job loss. And this has caused people to just panic. To that note, I've had several patients, one in particular that I can think of, that he had a job, but he was freaking out because people were not taking the social distancing seriously. So he had a mental decompensation happen with him where he quit his job. He was no longer talking with his family. It was so bizarre to see him absolutely just decompensate. And it was very sad. And again, he went from being employed to now not being employed because he just had so much fear. A lot of my patients who have anxiety disorders already, it's just, I've seen people just really regress and decompensate. It's very, very sad. So that's what I have been seeing. And then from a case management perspective, it's very hard because we don't have the manpower for some of these resources. So in San Antonio, we experienced where the homeless shelters were no longer taking patients. So when we need to discharge them, where do we go? We don't even have shelters to put them in. So it's just impacted us in ways that I could never have predicted.
Yeah.
It's also impacted some of our providers as well. We have actually had patients that are living in skilled nursing facilities that have said that the hospice providers are not wanting to go into a skilled nursing facility because they find out there's some COVID positive patients, and it's just the domino effect. I have no words.
Okay, so I have some comments on what you just said, but so I'm going to try to get these 3 points out as quickly. One, a couple of weeks ago, I posted that I have the most brilliant and beautiful friends on Facebook, and I submit Exhibit A, Dr. Perez and Dr. Rasimas. So thank you for joining us and giving your perspective on that. I think what I want to synthesize with what JJ has said and what you have said now is that we really have failed. Okay, and it's not. It is is so evident, and now we have to re-engineer our approach. But we have now we're gathering the evidence on our failures through these conversations. There are conduits to get these the pearls out of these conversations to people that can perhaps act on them. So John and I are that conduit. I think we're going to try to do our best to be that conduit. So that was my second thought. My third thought is, and I'm going to try to be controversial here because of the voices that we've heard so far, like John and others that have emailed me, and friends who have said, when is this going to get back to normal? Like JJ said, well, what do you define as normal? But ultimately, people are trying to understand two things. One, did we overreact, or did we overreact in a way that was a blanket, and instead of providing some sort of targeted containment and way of dealing with this? That's one question. Did we overreact? Because by doing what we did, we have put people who were at risk, that you just described, at even greater risk. Okay, so that's one point of evidence, and one question that I will pose to JJ and you: did we overreact, or did we inappropriately react? I think JJ covered that we most definitely inappropriately did, but overreact is the question that I'm getting. And then the second question would be, at the nexus of social work and the evidence that Anna just provided in her experience so far, and therapy and psychiatry, besides the enormous stress put on these people that Anna just described socioeconomically, what else is there that we can do? Is there a strategy for suicide prevention in these types of communities, for providing support for these, for what you just heard described? JJ, I'll let you go first.
As I listened to what Anna said, the association that I had is to think about expanding one of the core principles and key insights from the recovery community. And that is that one of the things that's emphasized in many programs is the problem that in order to break a cycle of addiction, one needs to modify the routines of life that help to perpetuate it. One of the mantras in some of the 12-step programs is this notion of people, places, and things. The idea that there are people that we spend our time with, there are places that we go, and there are things that we do that are tied to the addictive behavior that keep us in close proximity to the temptations to do it and the reinforcement of it. And if we're going to actually break out of that, we need to replace it with something else. And so there's a corollary to that insight, and it's a simpler one, and that's this problem. Nature abhors a vacuum. So why do I highlight that? Because most of the response to the explosion of the pandemic problem and what we have said that people need to do is basically equating to telling them, don't do X, fill in the blank. Don't do X. Don't do this. Don't go out. Don't go to work. Don't get close to each other. Don't touch each other. Don't, right? But we did not say do, and fill in blanks for do. And I see Anna nodding because that's one of the critical things that we do in the addiction, in the addiction and recovery community. We don't just say, don't drink. Are you kidding me? People heard don't drink 50,000 times from all the people in their lives before they ever finally came to treatment. If knowing that it wasn't a really healthy thing to overuse substances was enough to break it, we wouldn't have a job, right? So don't do is not helpful. And so what we need to be thinking about is, please don't do this. Please do this instead. There needs to be an instead, and the instead needs to be in the direction of health. positive for the individual who takes it on himself, and positive in the service of the other people in that person's lives. And that's why also the recovery community emphasizes service once people have sort of shored up their own individual foundation. And those are really a lot of the things that we're lacking in our response. I do think that that dovetails to your question about whether or not we could have a suicide prevention initiative. But it does boil down to the fact that not everybody is wired the same way. Not everyone who ends their own lives or is at risk to do so has the same pathway to that endpoint. You know, there are statistics, and we can come up with numbers about how many people die by their own hand within a given community in a given year. And I got to tell you, there's always been this urge or drive or desire to design studies and come up with initiatives that are the thing to do to prevent all of the suicides. In fact, so this is a place where, despite the fact that I had all those years learning from and working within and working for the government, there's one thing about the government's approach here that drives me up the wall. They've called their suicide prevention initiative the Zero Suicide Initiative.
Yeah.
And that is a setup for failure right from the beginning, because we will not ever stop everyone from ending their own lives. In fact, we actually have a pretty robust ethical backing for the idea that some people should be supported in their desire to shorten their own lives artificially because they are suffering, because it is justified to ask a physician to assist. We don't need to get into a debate about physician-assisted death here, but my point is that saying that our goal should be zero suicides is a setup for failure right from the beginning. And more importantly, it's this idea that all the suicides are the same, and we need to go from whatever the number is to zero by doing one thing.
Yeah.
This is the place where we need to embrace human difference, not sameness, and realize that some people are at risk of ending their own lives if they feel overwhelmingly panicked by the possibility of getting a COVID infection, like the gentleman I talked about before who killed himself in our hospital. But that's not the determining factor for suicide risk for somebody else. For somebody else, it might be me if I feel shameful that I let down a patient and allowed them to die when I could have saved them. And I feel so bad about it that I don't feel like I deserve to live. So that's what's going to end my life. It isn't panic, it's shame. For other people, it's rage without an appropriate target. Some people are so furious about this terrible situation that we're all in, so upset about it, so angry, but they also have a really strong conscience and they know that they really shouldn't kill anybody else. And the only target that's available to them is themselves. And so in this insidiously, psychologically terrible way, the person they attack is the person they see in the mirror, even though their goal isn't really to be dead. And so you see, if we're going to be helpful, we need to recognize that there are different determinants for different people about what gets them in trouble. And so that's why I would advise that what we do is we tie our COVID test records to a public health initiative that starts first and foremost with reaching out and asking questions, not pointing at people, not telling them more what to do, not directing them places, and not forcing them to have resources that we think should be good for everybody. This will be good for you, do yoga. This will be good for you, learn mindfulness. This will be good for you, go get exercise. This will be good for you, eat tofu instead of beef. Like, how about you got a COVID positive test? How are you doing now? Talk to me about how your life is different now as compared to what it was before you were told what you needed to do. Are you having any challenges meeting the demands of what people asked you to do after you isolated? What are the things that you can't do for yourself now that you always were used to doing and now they were taken from you? Questions, not answers, because the real solution for each individual comes from within her own experience, not imposed from the outside by somebody else who's an expert. And I'm supposed to be a suicide expert, and I'm telling you I am not the expert in what saves individual people from suicides. It's the people who are actually at risk and on that walk who need a reflection with somebody else who can guide them to their own way out, not somebody telling them what to do and just throwing something at them that should be a one-size-fits-all resources that fixes it. So this is the embracing sameness and difference dynamic tension that I think really, that's my favorite thing that came into my mind just by being here tonight with you, because it's just, it comes up over and over as I think about what we need to do.
Yeah, outstanding. Okay, so here is the scenario. I think we've had a couple of comments from my friends and the guys have been with us from like the beginning, like Jeff and Terry. So I want to open the floor to see if they have any comments, because I know Terry said that the first year is very important in sobriety, and if he has any thoughts he wants to share, I'd love to open it to Terry and then also to Jeff, and then I also see Lauren is here, and then we'll take it back to Anna if she's still available. I will not yell at her for Zooming while driving. She is in San Antonio and all the roads are straight and flat, so but I'm so glad she was able to join it. Clearly she was between between some engagements. But all right, Terry, go ahead if you're there.
No, I'm saying Zoom meetings are such a poor replacement for what's actually needed. Someone new to recovery, it's you take the connection away when they need it the most. You're putting them under the most pressure to go back out. It's as simple as that. Success in the beginning, if you're going to recovery through a 12-step meeting, is having that inclusion. You're coming out of a period of your life where you're emotionally stunted, intellectually stunted, all these other things. You need people of like minds to help you through that, and that connection is not, you're not going to get that through a Zoom meeting. They're kind of a farce to me.
Yeah, absolutely. Now, do you know, or have you heard anything about in your community whether there are people that are struggling because of being isolated at home? Anything that
Yes, a lot. The majority of the newer people, and I don't know with what Dr. Anna said, that someone of 10 years relapse going through this.
Yeah.
To me, that's a foundation issue. That isn't a pandemic issue to me.
Okay.
You know what I mean? At 10 years sober, you should have a little bit more feet under you, that you're not, I have a long time at the tables, a long time at the tables. So someone 2 years and under, I could see where the sudden vacuum where they've been counting on the personal connection is suddenly gone. I can understand that. Maybe not 10 years, but I'm not everybody. So, I can't address that. I don't know the person.
Yeah, clearly. Yeah, no, but I understand where you're going. Jeff, did you have something to say?
Hey, Sanjay, how are you?
Great. How are you, Jeff? Good to see you.
I'm good, thank you. No, actually, I was actually been trying to listen and absorb as much as possible. I was making more offhand remarks than anything serious or that should be considered, as essential. So.
Okay, gotcha. I was scrolling through and I was making sure that everybody was getting heard and at least questions were getting,
I'm just glad that no horses were hurt in the making of this town hall.
We don't know that yet.
All right, take care.
Zooming in San Antonio, so we don't know that yet. There's back. Lauren, are you with us?
Yes, I am.
Did you have any questions?
I wanted to just mention, we always call it social distancing.
Yeah.
I think we should call it physical distancing.
Here. That's wonderful. I've been saying that for so long. Thank you for that. Keep going. Go. Go. That's great.
We need the social closeness now, and more than ever. So, yeah. And then the other thing I wanted to mention, you're talking about availability of alcohol. I'm a medical cannabis user. I live in Illinois, and cannabis has been, medical cannabis program here has been legal for about 6 years. And I've had my license for, 4 years now. But we just went recreational in January. And now all of the dispensaries in the area are closed down. And there's a lot of people that really need that medicine. and it is medicine. I use it because I have a myopathy, a muscle disease, and it helps me with pain and the ability to sleep. So I'm just kind of wondering about them and hoping that those people will be okay.
Because access has been curtailed, right, Laureen? Right? Yeah, that's very difficult.
Yeah. Karen, do you have a question?
Yeah, Cindy is indicating that she has a question. I think it might be a little too long for her to write it in the chat.
No,
so
please. Yeah, let's hear it. Absolutely.
We're gonna have her unmute herself and ask it.
Okay.
Take it away, Cindy.
Okay, thanks. Can you hear me okay?
Yeah.
Yeah, because I've got headphones on because my speaker's okay. I guess it's more comment than question. At the beginning of this, there was a statement to the effect that we had a pandemic plan left by the prior administration, and it was discarded by the current administration. I don't know what was in that plan, but it sounds like going forward, there should be a mental health component as well as a physical health component, because both types of health are affected and need to be addressed. I guess that's what I had to say.
That's awesome. So I will post the 59-page playbook on the research group that I have. Of course I have it. You know I have it. So I'll post that. But JJ, comment on, absolutely. So there is a physical health plan, and there must be. You're right.
Very nice. Absolutely. Well, yes. I mean, it's like building a machine and asking it to then serve you and do its function without fuel. If you're going to say, I have this great plan, I will build what is necessary to endure this pandemic, but then I won't fuel it, because what fuels us, of course, it's our desire to survive. It's our humanity. It's the meaning of our lives. And if you don't account for those and you just say, well, as long as you're alive, that'll be okay. Well, not really, actually. If you have no job, no prospects to keep the flow of food into your house, no way to be connected to things that are meaningful to you, then there's that logical, obvious question in all of our minds: what are we living for? What's worth trying to fight to survive for? So you're right. That has got to go hand in hand with it, because otherwise it's a bridge to nowhere. It's not surviving for any purpose, right? Good stuff. Very nice.
JJ, I know that you've been with us for 2 hours, so I don't want to keep you any longer. But if there are any other questions for Dr. Rasimas before he leaves, again, he has worked all day. He came home and he's in his scrubs and joining us for the last 2 hours, so I can't thank him enough. But if there's any other questions for him so that we could have anyone ask, and then I'd like to let him go and get some rest.
I'm just wondering if you could comment. I don't know if you saw my big long chat there, but can you hear me? Hopefully. My internet's a little iffy. I was just wondering, so one of the things that's being processed, certainly in my little world here, is a number of friends and connections who are concerned about Mikovits or Mikovits' book and the her what she's saying about Fauci and about the whole issue of Bill Gates and vaccines and everything. And I hope that hope you can all hear me. My screen is very choppy, but I guess I've been processing that and trying to be open to perspectives, and I think there's some legitimate questions that are in some of the things that she writes about, and most people don't obviously have clinical knowledge at the level that you all would, and it's hard, right, that most people don't have access to that information, and I think there experience of broken trust or people not having their needs adequately met in systems the way they are in our governments. So I was wondering if you could comment on that and mental health in light of that. Thank you.
Very good. You did cut out a tiny bit here and there, Giselle, but I got the gist of it, and I appreciate the paragraph that you wrote, because I do think there is a psychology to this, and it isn't, when we talk about mental health, your comment speaks to more of the overall health of all of us as a community together, and our ability to stay bonded together with us and have our priorities straight under threat. And it is a really unfortunate consequence, but you make a good point that this is not an all or nothing proposition. So I have two thoughts that I associate to when I think about where this problem could be remedied. One is a harder one, and I'll mention it first because I don't have an optimistic way to fix it right away. But when we face this crisis of suspicion of expertise, where we get this automatic resistance to being told things and then correspondingly being told what to do in response to them or alongside, and there's this automatic rejection of expertise, what I would like to see us think about in a really intentional way in our country is to think about restructuring educational and economic systems to make a larger percentage of our population feel and genuinely know that they too are experts in something. Because I think if more people felt that they really knew something, were really good at it, and we all as a society valued them for it, they would then be less likely to look at someone else's expertise and dismiss it out of hand, because they would first value it for themselves. And then when someone came on and said, I have something serious to tell you about a virus, a really horrible thing that's killing people that you can't even see, but I'm asking you to believe in its existence because I know something about it, please listen to me. People would be less likely to say, what, you're full of shit. That thing isn't even, I can't even see it. It can't possibly even be a thing. You've made this thing up. You're just trying to make my life more difficult. But if they themselves could say to themselves honestly, I live in a world that really values me for my ability to craft things with my hands and make products that people depend upon, and they pay me a reasonable wage for it. They lift me up and they say, he works with wood in a way that doctor guy over there could never do. And that's true. I could never do that kind of work. The problem is we don't value those folks. We fight over whether or not they even can make minimum wage, and we don't give them resources to feel like they have expertise. And so you can see why they would want to react against any other expert who already has power telling them what to do. Like, who's this guy who already makes $500,000 a year having the nerve to make my life even more difficult than it already is? So it's easy for folks like that to then get sucked up into conspiracy theories. So that's one thing. It takes a big effort to fix the situation through that mechanism, but I really do think that that's a main way that it gets fixed. The other aspect of it that's a little bit lower hanging fruit, a little bit easier to deal with, is this idea of really needing to ask before we tell, asking people where they're coming from before we say the way that things are. This tension between certainty and strength and loud voices being equated with strength, and actually humility being something that is communicated as weak, has got us in a bad bind, because we all should have acknowledged that we should have had a whole lot of humility when we first learned of this new pathogen and didn't truly know what to do. But the reason to then take it extra seriously and to really lock down, be careful, take care of each other, was because we could not predict where it was going to go. Rather than saying, I certainly know what's going to happen. Here's this model, and if you don't follow my model, then there's a problem. And, I think Fauci's remarkable because he is truly humble despite the fact that he knows a ton of things. But he's been put up in a position where he is now the target. But the reality is he models humility pretty darn well, despite the fact that he knows incredible amounts of relevant things. But he's working for an administration that otherwise doesn't say the reason why we're taking this so seriously is we all have to acknowledge that we are all fearful, top down. And it is not just my need to be a leader for you, but also my fear for you, because I am your servant. I am responsible for you. That's what makes me want to slow down and take this seriously and ask you to come along with me, rather than insisting, do it this way, don't do it this way. Certainty, when there is no reason to be certain, is really hollow, and it resonates badly with people. And so, Mikovic plays on that, right? She's able to say, these people they just always seem to know, but there's another way of looking at it. And if we don't model openness to some other way of looking at it, we think we're fighting against her and we're going to win, but she's got the upper hand because she models uncertainty. And that's something we need to embrace too. We really do. Anyway, I'm sort of rambling at this point, but openness to the possibility of uncertainty is actually powerful, because then it makes it so that certain, this side versus that side battle, you take away the battle and you say, actually, your uncertainty over there is actually part of my way of thinking too, right? I embrace what you have to worry about as well. I just have more things that weigh us on this side. And if we go that route, what if we're right? What if we're wrong? If we go this route, what if we're right? What if we're wrong? Well, the consequences of choosing this are safer. So that's the reason why I would prefer that we go my way. But I get it that I'm not certain. But if we go your way of thinking about how it is, the risk is going to be much greater. That way of modeling the discussion would probably be more palatable to more people. That'd be my guess.
That's an outstanding answer. Outstanding. And I just want to add one thing, if you'll allow me.
Sure.
The recognition of humility as a strength and not a weakness is absent right now. So when Fauci said this poses a small risk to us in the United States in January, when he was asked about it, people are pointing at him and saying he was wrong. When Surgeon General said we don't need masks right now in February, people point back to it and say, look, they already said don't use masks. And they're using a certain position of authority to identify as a source of truth, rather than truth being an authority. So one thing that kind of raised the hair on the back of my neck initially in your answer was, let's treat everyone as possessing some expertise and have respect for the expertise that people have. You're a mechanic, you're a carpenter, and I do. And, I live my life like that, and we all should. Like I said to you the other day, my dad considered his healthcare team not just the nurses in the CCU, the cardiac. It was the guy that cleared the snow from the path from his car to the hospital. That was part of the healthcare team. Okay, everyone is that allowed him to do his work is part of the healthcare team and deserves exactly the same respect. That's one thing. But I value humility more.
Yeah.
Sorry. I want everybody to understand that I take certain pride in saying I was wrong, because it means that I'm intellectually plastic enough to recognize and change an opinion.
Yeah. Well, here, let me loop back around to something that has been mostly the focus of your previous installments of this on my way out. I'm going to loop it back around to the topics that you've been spending more time addressing. You've touched on a couple of times tonight this concern about us overreacting and mobilizing more resources than were needed, and over-calculating the number of ventilators and all these sorts of things. And folks then saying, we overdid it and there was harm instead. One of the things that happened, actually, we mobilized all those ventilators because medicine up to this point had told us that when people have really ugly looking scans on their lungs, when their testing of their oxygen levels in their blood are really dreadfully abnormal, and their oxygen saturation readings that we get are so low, we need to jump in and support their breathing with a machine, because otherwise they cannot survive. because that's what all of medicine up to this point had basically told us about what the parameters are when we jump in. And so since we saw those patients with those values, those lab tests, those manifestations, the doctor said, holy crow, do we need a ton of ventilators?
Yeah.
But you know what happened? It isn't just a matter of doing a great job of flattening the curve, which made it so, thank goodness we didn't need as many ventilators. That's the way Cuomo likes to tell that story, because that's, you know, that politically helps him in a way. But there's medicine to this too that is driven by humility. Pulmonary care doctors realized that their assumption that this was the typical acute lung disease that they had already become acquainted with was actually modified by experience. They started to realize, you know what, these numbers are extraordinarily abnormal and low. However, people are still alive. They're still breathing and their brains are functioning. How is this possible? And since they were willing to embrace that newness, the next step that they took was what? You know this. They started intubating fewer people. They put fewer people on ventilators despite how bad the numbers looked. And it turned out that their outcomes were either as good or even better because they caused less lung damage from the ventilator itself, and they supported people through the illness naturally on their own. So what did that mean? That meant we needed fewer ventilators. But we never would have known we needed fewer ventilators unless the doctors were willing to be humble and say, holy crow, my set of tools puts me at the front line and I have to do something, but now I need to do something different from what I've ever done before. And that changes the resource calculation on the fly. And then we have all these ventilators that we don't need. Is that a bad thing? Would it have been better had the doctor say, nope, I still intubate everybody whose numbers look like this? And what do? They kill more people, but they use the ventilators. Thank God they use the ventilators that we gave them. Are you kidding me?
Yeah.
No, the humility is what allowed us to grow and move our practice forward. So, that's true not just of mental health and flexibility and things like that. That's true of the medical science for the lung as well too. So I'll leave you with this. Mental flexibility is a hallmark of mental well-being. Flexibility is really a hallmark of it. We can talk about pathology, DSM diagnoses, label people with all sorts of disorders, but we don't tend to talk about the positive side of mental health. And there are markers of what we know makes people better off and less diseased and more able to do well. And so when our latest crop of psychiatrists in training graduated this year, this was the graduation speech to them. It was to remind them that flexibility and belief in the ability of human beings to adapt is actually a sign that we are on the right side of things. And that's what we should be enhancing. So although psychiatrists are trained to identify abnormality and sickness for a living, we should also be recognizing when we see strength and resilience, and we should be working to enhance it. So, keep your head up, keep fighting the good fight, keep making sure that you beat back misinformation. But also when you see positivity, embrace it, highlight it, and lift each other up about it. And if it requires vastly changing our routines, finding a way to do things in a new way, that is a sign that you are on the side of survival. True mental health means making an adaptation to a new situation and not saying it cannot be done because this was the way it always was and I rely upon it, but really being open to the possibility of a new way of doing it and not just saying it's either all or none. It's either the way it was because I count on that and that's the meaning of my life, or I can't have it. Then what's the corollary of that? Then why go on? So there has to be a way of thinking about a new way of doing it. So a new way going forward. We'll do it together. I look forward to coming back to one of these in the future. I know you'd like to keep talking, but I'm going to leave you to wrap it up on your own, okay? If that's all right.
Thank you so much, Dr. J.J. Rasimas. Be safe, be healthy. We so appreciate you joining us, and we'll have you back with a great honor to have you.
Absolutely. So we want to thank everyone for joining us tonight. We are at our time limit for our live stream. So we're going to jump off of that now. If people want to hang out a little bit longer, we will leave the room open. Sanjay will stick around, I think, and we can go from there. But we will be back next week. The link for our broadcast next week will be different. So if you've bookmarked the link for the last couple weeks, there will be a new one that will be posted on the page. in the groups, in the events, in the email, everywhere. We will have to get that out to you for next week. So once again, my name is John Taw, and I want to again thank Anna, and JJ and Sanjay for their time tonight. Once again, we will stick around a little bit longer. Have a great night, everyone. We're out.
Awesome, John. That was beautiful. Wonderfully done. Thank you so much. Can you give me that screen where I can see everybody? Oh, I see it. Ah, there's my people. Oh, so what'd you think, guys?
I was on my best behavior.
Yes, yeah. You didn't have to be though. Don't worry about it. Yeah.
Wow, he was great. I didn't think that I needed mental health help until after he was finished, and I realized, oh my God, he made me feel so much happier.
Yeah, he's incredible. He is the smartest person I know. He's the smartest person I've ever met. I've been to 44 health systems across the world, and I've met incredible professionals in all kinds of different biomedical fields. And I was lucky enough to go to high school with him. So I've known him since we were best friends at freshman year of high school.
Oh, wow.
And I've watched Anna over the last, I think, 8 years, and progressed through her education to become a Ph.D. level. And she's brilliant. And she's so full of heart and warmth. And it's brilliant. Her observations on everything that she does in her professional life, personal life. Happy to come with us and discuss things like this. I thought this one is the best one we've done so far. I really think that this one was awesome, and it had no sign, none of my favorite stuff in it. No charts and graphs. So
I thought it was funny that he zoned in that I asked him a little bit of a database question, but that was all from you, Sanjay. That wasn't me.
I'm a bad influence.
I got blamed for that part.
Yeah. So I see Madeline. Is her audio working this time? No, it's not. John, I'm sending her a headset. Get her address. I think John went to the bathroom. And who else? Lauren. I don't know exactly where all of you guys are from. I know obviously Terry, Jeff, Karen, Pam Bullahan's here, right? Pam, where are you from? You're on mute. How do we unmute everybody?
Everybody's unmuted. Be careful what you say or what noises you make, Terry.
Thank you.
You too, Terry.
Leslie's for Game of Thrones, and Terry's got his family behind him.
It looks like my ex-in-laws, actually.
Can you hear me?
Oh, man. So can you believe it? Week 11. John and I have been doing this for 11 weeks. And it's 2 hours to us here in this group, but I didn't realize how much work it was going to be, like to get read, like all the, like I'm normally reading, like I'm normally catching up on the science, but as part of my job in evidence-based medicine, pop health, clinical genomics, to keep abreast of new science. But the pace of this stuff is insane. I mean, the pace is just extraordinary. and one of the things I hope you will come to realize in the next couple of weeks is that 50-60% of the papers that are being submitted right now, I was joking with my friend, they're experiments that were done just to show other scientists not to do that experiment. They're just like, look, we did this, we learned nothing, so please don't do this. You know? So you just like flipping through all this stuff. And then obviously, so let's open it up for politics now that we're among friends.
Oh, what a week I've had.
What a week, huh? That poor guy, JJ, it's hospital. They saw George Floyd.
Yeah.
It's a kind
There's so many people who got their feedback, but
where do you start on a week like this?
Seriously, I have no idea. I mean, before this week started, you know, I was a lefty, yeah, and I was a progressive, kind of an activist, and now I'm getting a BLM tattoo on my neck, and I'm gonna, join Antifa. So I've ordered my black hoodie and all that. I'm making light of it, but for God's sake, what is it going to take to wake up, the conscience of this country? And then all of these people sending me, I went to school with a number of African-American students. That was very rare in my community to have people of color when growing up in northeastern Pennsylvania. And now they're married and they have children, and they're emailing me and saying, this is the first time I've been afraid to let my son, go to the grocery store alone or go do whatever. And, and then mom's emailing, how do you talk to your sons about what's going on? And, my daughter's from my first marriage is Indian appearance, just like me, dark skin. My boys are, Karen and I have our two boys together, and they easily pass for just kind of a darker complexion white children, and I couldn't believe how many people contacted me this week. Couldn't believe it. Turned in, I was, the COVID guy for everybody for the last couple of weeks, and now I'm buying black hoodies and getting combat boots and stuff.
I understand. I totally understand.
I'm kind of in the other situation. I'm in Gulf Coast, Florida, in a small community that most of the snowbirds have gone home. But, the people with the Confederate flags, and I've unfriended 5 contacts today alone.
Yeah.
People who came out, all lives matter, property over people.
Unbelievable.
And some of them are relatives. And I'm just, at first I was explaining why. Now I'm click. Bye. You're banned.
Good luck.
Well, it's like what you just said about doing experiments just to say what not to do. Talk about a Confederate flag. Yeah. I'm in New York City, and it's crazy. The helicopters, I know when they're out because the helicopters are there. I have a disability, or I would be out there marching too, but I have to stay in this time. I've 2 years out. I had a hip dysarticulation. I got hit by a big truck when I was on my bicycle downtown. But I used to go to whatever I could go to, and now I have to stay at home and just do social media about it. But this was great. I was thinking, oh yeah, I've been doing well so far. I don't need any mental health. And I started listening, and I tuned in late, and it was about, the side effects of mental health. And I was thinking, oh yeah, I don't really need that. But by the end, that was great.
Yeah, I've been asked to do this for quite some time. From our friends on the right, one of their talking points now is that we're going to lose more people, or as many people, from addiction and domestic violence and all of this stuff. And you should look into it. Let's see if there's statistics to back that up. The more I looked into it, it is a dagger they use, but there's also a huge amount of truth. People are suffering.
When it comes to addiction, there's a little bump, but
it's a constant at about 80,000 a year. Lost to overdose, suicide, drunk driving. You know, if you wanted to lump it together.
1 second. I forgot to show you guys this. This was supposed to be in the intro before JJ joined us, but I want to show you this. Okay, hold on. Can you see this?
Yeah.
Okay, here we go. Watch this. This is at the beginning of the year. Okay, I'm gonna take this forward. Look at the deaths. All right. On the 1st of January, we already had 2,300 recorded deaths due to malaria, malnutrition. Obviously, those are spillovers from last year. But here we go: malaria, malnutrition, homicide, Parkinson's, drowning, meningitis, influenza, alcohol, drugs, hepatitis, fire poisonings, terrorism, natural disaster, COVID at 0. This is, I think, United States, right? Yeah, United States. Here we go. Still pretty insignificant. February starts to ramp up. Mid-February, we have a significant amount of cases. End of February, beginning of March.
Okay.
And now we hit the doubling rate of 2 to 3 days. Okay, doubling rate of 2 to 3 days. And you'll see COVID. And this brings us to, I think, the end of
May.
Yeah.
End of April. Or, sorry, May.
May. There we go. So, I wanted to show that because there's a certain, certain group of people that are saying, and they've been saying this since the beginning. It's not as dangerous as flu. It won't kill as many people and all this other stuff. And also when you do the comparison to the other major causes of death, and of course that at the bottom of the chart is the disclaimer that says these are only the categories that form up less than 7% of all of the causes of death. So there's no heart disease on there. There's none of the major killers. And of course I have to vet the data, but it is it came from data scientists that used Johns Hopkins CSSE. So I don't want to argue over whether it's dangerous or not. What I want to do now is that we don't. There's not even an argument over whether we failed. We failed. So we didn't just fail in big cities. We had this gentleman, John Davies, join us from British Columbia, thankfully brought to us by Giselle to talk about how it has affected a small community, outside of the high risk category, and what kind of devastation. So we have failed. We have enough evidence to say that. So let's not, what's the R naught? Is it 2.3 or is it 2.7? I don't know. You go discuss that. Adults have other work to do now. Yeah. So now you see the real Sanjay coming out. The guy that's in the town halls, I have to be professional and reserved and all that stuff, but I'm upset. I'm upset this week by everything that I've seen, the lack of compassion, the lack of empathy, the rage, we've lost ourselves, we've lost our conscience, we've lost our soul, we've lost our ability and desire to love and take care of each other. So that's my spiel.
Oh yeah.
But
What's that?
have we really? You said we've failed.
Yeah.
Let's look at who's really to blame here. It's not the medical science.
No.
I mean, you were presented with a novel virus and you learned and you've made changes, and it's a normal evolution of a new disease. The failure has been leadership from our government. It could have been so much better. So let's point the blame to where it really is, and it's not on medical science.
Yeah. I wish we had one of our, Sandra Norton is usually joining us. She's joined us a couple of, 3-4 times now in a row. And she's from this area in northeastern Pennsylvania. She's from a family that I've been very close to. And her dad was my mom's patient at the Veterans Administration. And she's a conservative voice, okay? And, I don't disparage conservative voices. In fact, I'd love them to be here. I'd love them to contribute. I'd love them to share their thoughts and then hear ours. Because right now we're just yelling at each other. I'm guilty of it. I lose my temper, and listen, you're a dangerous freaking idiot. I'm done with you. And then I move on, right? But then there's the other stuff that you've got to look at each other's humanity. And she's been saying, look, all of my friends in small business, they don't know a single person that's been affected by COVID. They don't have anybody in their family that's gotten sick. There's nobody, blah, blah, blah,
Well,
yeah. Good for them.
But
it's not going to be like that forever.
Exactly. But that doesn't prevent her from wearing a mask. That doesn't prevent her from listening in on us and coming in and learning. And I'm proud of her for that. You know what I mean? Like, I'm proud of her for that. And I want her to be continuing to be part of our conversation. Am I going to call her, names for having voted for Trump? Yeah, I'm going to do that. I'm going to love her just the same. So I don't know. Okay, I'm done talking. You guys, your turn.
I think, well, one thing, John, did you want to say something?
Yeah. John, you're on mute. Go ahead.
No, I'm just here. I would say that if you're connecting in, which since we unmuted people, if you're on a phone, if you're on like something you're holding, every time you move, it cuts out the audio of whoever's speaking. So I'm re-muting people. So if you are trying to talk and you're muted, unmute yourself, talk, and then re-mute yourself.
Got it.
Also, JJ said in social work that he put in community organizers, and Karen and I shared a little smile, I think, because she's a community organizer, and I was a community organizer for a very long time with the unions and with all sorts of stuff. So, yay. Okay, I'm done.
My first job out of college was as a community organizer, too.
No war is won without boots on the ground.
So completely off topic of COVID.
Yeah.
So they had the Black Lives Matter protest in Wilkes-Barre, right?
Yes.
And I had to work, so I couldn't go. So friends of mine went, and they said, "Oh, it's real exciting because they're trying to get people now. Let's not we can debate the effectiveness of their strategy. They're getting people to contact their leaders and contact their government officials." And I said, "That's great. What government officials are they contacting? What are they asking them to do? What's the desired outcome?" And it's like, I don't know. I'm like, great. So let's all write letters to, I don't know, the assistant treasurer of the borough of Kingston, Pennsylvania, and that'll be real effective. And that's writing to your elected officials or writing to your community leaders. And I'm like, that is where unorganized organization is just like parents nodding. Like those of us who have done this for decades are saying to people, great, what is the message? And the other side of it is, great, Sanjay knows, and I'm not bragging, I can call the governor, I can call the Secretary of Health, the Commonwealth of Pennsylvania.
That's right.
So if you're gonna protest, have you attempted to communicate with these people? So they're like all up in arms because the mayor of Wilkes-Barre is a gray-haired white guy. Right, well, he's the most progressive gray-haired white guy the city of Wilkes-Barre has ever had as a mayor, and is doing a bunch of good things, but you're not bothering to try to talk to people because that's gone. That's obsolete.
Then you're just flailing.
No, that was me. I was flailing.
Yeah,
try not to knock over my beverage.
Look, I posted something. I don't know what I'm doing. I have to ask John, but I just did it anyway because I was upset. I posted over the last couple of weeks that, yeah, you can do this protest and all this other stuff. That's fine to express yourself. But if it doesn't translate into action at a community level, then it's useless. It's totally useless. And you're wasting your time and energy, and you're putting yourself at risk for health and other reasons. And then I went and I like I do, to all of these sites where they had toolkits on how to talk to your police department if you're having problems with them, whether it's from the ACLU or whether it's from the police executive group, which they have, like they come together and they talk about best practices on community policing, and they have a toolkit for, the shitty police departments, and the ones that care have come together and said, positive deviance, this is what we do, this is how we got better. This is how we got our communities to listen to us and talk to us. And they put together this stuff, and, people who really care from the community came together with people from the police forces that really care. And they said, all right, here's the stuff. You could use it if you need to initiate positive change in your community. And I went and I just read and read and read. And John knows, we sleep like 2-3 hours a night anymore. And, and so I bundled it up and I put it on the Google Drive, and I have 2 or 3 posts about, look, if you want this in your community, you're pissed at your police, download it, print it, and here are the steps to go. Here are the steps to go and talk to them. Okay. And if they're resistant, then go find a lawyer that'll do it pro bono, stand beside you when you go talk to them. And if you can't find that, here's the ACLU. And if your community is big enough and shitty enough, they'll send a big gun. Okay. But screaming in the street is not going to do anything for very long. It'll get you media coverage, and you get your 15 minutes of fame. And that's it.
I had a clarification moment with a coworker today, and I said there are 3 words. There's a protest, a riot, and there's looting.
Yeah.
These 3 things are not related. Yeah. Except for the fact that they happen at the same time.
Right.
Right? The people who are looting, the people who are protesting are doing it for some sort of social cause, justice cause. The people who are rioting have given up on the protest and have moved on. They are not but they are not necessarily people. Let me back that up. People who have either moved on from protesting or have ignored protesting and gone straight to rioting.
Yeah.
People who are looting have nothing to do with the other 2 and have and are just using the situation to create a distraction from the fact that they're greedy bastards that are stealing stuff.
Yeah.
Destroying stuff.
Yeah, absolutely. Absolutely.
That's why I was glad. That's why I was glad they went in the day today, because it cut all that out, or at least that part of the time. You could tell that there were sincere people and not just looters.
Yeah. And again, remember, in this era, it could be happening and then no one would know if the media has lost their attention span. So Standing Rock protests, they got their 15 minutes of fame, but there were months of living in mud and trying to stop what was happening. Okay. So John, to me, I love the man. So I've assembled a kind of Avengers here, right, when it comes to COVID, but I've got doctors that I'm trying to get to join, but they're on call and they're in a different time zone. So from Spain and from Malaysia and from India and from Italy and from the UK and trying to find a friend that actually is working in Western Australia and just get their perspectives and try to share best practices and information on what's working. My MD PhD when it comes to organization is John Daw.
Right.
Okay, when
That's me.
Activism and getting things done, it's John. Like what was I doing? I was tooling around trying to get Zoom to work the first 2 times. Now look at us. It's pretty awesome. And even just my mask, the goofy mask video has like 27,000 views. I'm like, well, good, because people are like going to learn at least the basic. Because it's just.
You even have your own theme music too. You have music.
Thanks to John. So, yeah, this is great. Giselle, thank you again. And John Davies, thank you. I hope I'm pronouncing his last name correctly. Okay.
Yes, I think so. That's it, right, John? Yeah.
So it was actually enormously powerful for you guys to have joined us tonight and given your perspective, because not just because you're a small community, but what you actually shared is very valuable and poignant right now. So
JJ took it to a really nice level, because at my best, when I'm not swinging between sadness and anger, I'm seeing the cultural perspective here. One day we might actually have a Monty Python-esque virus where we're bringing out our dead, but
yeah, right.
and this is kind of like a dress rehearsal, maybe for the real one. So as an exercise in communication, it's fascinating. I find it really hard to give up on anybody, because I'm continuously trying to find a way to bridge the polarizations, even though I annoy people because I'm a skeptic to the core and I'll question everything over and over again. But really, I'm trying to find an agreement, and I think this is the value of this kind of a meeting. And when I read your LinkedIn, Sanjay, I was going, what is this guy doing? And then I see you've actually got a real people side. You're not just a numbers guy. So thank you.
Wow.
Yeah, just for, oh, sorry.
Yeah, go ahead, Giselle, go ahead.
I was just going to say, just for context, so John and I don't know each other that well, but I used to live in the community that John is living in. And so we're Facebook friends somehow through like community activism type stuff. I think the Grace Islet era a few years ago, John. And
right.
So he and I have had like, words and sort of like on different sides of the issue, right? Around the whole like pandemic Mikovits thing. But I see you questioning in several directions, John, and I'm also trying to stand in that place of openness, and I thought that JJ really nailed it, right?
Oh yeah.
Yeah, JJ gets it.
Not polar at these times, because that happens, just rifts in the fabric everywhere with that. So anyway, thank you so much for having us here.
Well, and it's always nice to have Canadians on the web on the meeting, because you could blame the virus on Canada, and Canadians would say that they were sorry for it. And yeah, I mean, Canada has now apologized for Bryan Adams, Justin Bieber, and the coronavirus, so we're good.
Yeah, but we gave you Ben Affleck. Come on, we gave you a few other notable. Jim Carrey.
We've got enough ice to build a real wall.
Yeah, you guys are right, exactly.
Because I organize around healthcare, whenever someone introduces themselves as Canadian, my mind is immediately single payer.
Butterflies start going around Karen's head.
She is single payer.
Well, thank you guys. And we'll see you again next week. Thank you
Hey,
so much.
Sanjay.
Yeah, Terry.
Yeah, I dropped a link in the chat
Okay.
for your MD page. If anyone hasn't liked it already, just shoot on over there and click like, and you'll be able to follow along with some of the information that's going on that page.
I did forget to, because we skipped a couple of things to make sure that JJ had enough time. I've asked Karen to help, and actually Terry is going to help us with, he's going to be our admin for the resource page. So that's outstanding, and he has experience. So with promotion and all this other stuff. So I'm going to let you all go. Have a great night. Thank you again. We'll see your beautiful faces again next week. Bye.
Thank you.
Thank you.
Thanks.